Hi, everybody. Welcome to Be Time. I'm Beth Bierbauer, healthcare executive, author, and host of this podcast. Be Time is a podcast for individuals who want to invest in themselves and their careers through continuous learning. Each week on Be Time, I have the opportunity to interview a seasoned executive or other individual, and we talk about a variety of business topics. So whether you're with a large corporation, a small business, or a startup, whether you're inside the industry or out, Be Time has something for you to help you stay on top of your game. Now, before we get started, I'd like to ask you a favor. Please consider going on to your favorite podcast platform and giving us a 5-star review. It certainly boosts our ratings, but it also helps others discover good content. So let's get started. The CDC estimates that 34.2 million Americans are diagnosed with diabetes. In 2018 alone, 1.5 million new cases of diabetes were diagnosed, and the prevalence of this disease is on the rise. Now, those of you who do not live with diabetes may think that this condition is purely under control with medication, and in many cases you would be right, but there is a lot more to diabetes than many of us know, and we're going to find out about that today. Did you know, for example, that diabetes is the leading cause of nontraumatic lower extremity amputations in the United States? And as high as 1 in 4 individuals that develop a diabetic foot ulcer might expect to have their lower extremity amputated. And did you also know that foot ulcers are in fact preventable? I have a hard time wrapping my head around amputations occurring in this day and age when foot ulcers are in fact preventable. So I really wanted to dig deeper into this issue so that I could understand the cause of diabetic foot ulcers and what we should be doing to ensure that we can either prevent diabetic foot ulcers or that we can catch them early enough to avoid amputations. Luckily, today I have an expert with me who's going to share his knowledge on this issue, what his company is doing to prevent diabetic foot ulcers. With me is Dr. Jon Bloom. Jon is a board-certified physician and entrepreneur. For the last 2 decades, he has spent his time in healthcare delivery, technology development, patient monitoring, and biomedical research. He is the CEO and co-founder of a company called Podimeditrics. It's a care management company that helps prevent diabetic foot amputations and the debilitating costs and complications of diabetes. He co-founded Podimeditrics in 2011 while he was still a student at MIT Sloan School of Management. Now, I'm not going to tell you much more than that because what I would like is for Jon to share his story, what inspired him to take on this market, and for him to explain exactly what his intervention is and how it works. It is simply brilliant. You want to stay tuned for this. You won't want to miss this. So please join me in welcoming Jon Bloom to Be Time. Jon, welcome to Be Time.
Good morning. Excited to be here today.
Well, we are very glad to have you. So Jon, I kept our audience in suspense, and I'm going to do that for a few more minutes. But why don't you start out by telling us what problem is it that you are trying to solve and what inspired you to solve that problem?
Yeah, so the diabetic amputation, diabetes, of course, a big problem in the United States and in the world. What isn't as well recognized is that as much as 1/3 of the spend we have on diabetes is related to complications of the lower extremity of the foot and leg. And the major driver of that are these wounds called diabetic foot ulcers, which if they're not caught early enough, they can lead to amputation. It's this complication where you lose your independence. In some populations, the fiber mortality is as high as 70%. And they shouldn't happen anymore, not with the technology that we have. And it was just, I just remember two stories. One is growing up with my dad in the VA, and I remember seeing veterans in wheelchairs with a missing leg. And I used to think that was all trauma. It wasn't until years later in medical training that I realized that was diabetes. And the other one would be, now fast forward, I'm in anesthesia, and I would spend sometimes whole days doing nothing but amps, which is this crazily, what a tragedy. How could it have gotten, we missed the opportunity to fix it earlier, and now we're, losing legs, throughout the day. It was just something it really shouldn't happen anymore, and we felt like we had to make a difference there.
Right. Yeah. I was really trying to get my head around it when I was doing some of the research. I just could not believe that in this day and age, when foot ulcers are in fact preventable, that so many people, I think I read as many as 1 in 4 people who get a diabetic foot ulcer could expect to possibly lose their leg.
Yeah.
Just
Yeah.
incredible. So, what are some of the things that we can do just in general? What are some of the current preventable measures that and interventions have been taken prior to your invention?
Well, it probably still the most common practice is, we ask this patient to do daily foot checks and we try to get them into the clinic as often as possible. The challenge is, of course, that this patient is typically overwhelmed with their healthcare. The patient at risk for an amputation almost always also has, coronary artery disease, chronic obstructive pulmonary disease, the typical cardiopulmonary other comorbidities. So they're overwhelmed, and now we have them do daily foot checks. It's often challenging for them to figure out how to pull that into their day.
Sure.
Plus, we try to get them into preventative visits, and often, we this is a patient population that can be affected, lower socioeconomic status, so even transportation, things many of us take for granted, this patient doesn't necessarily always have access to it. On top of that, these daily foot checks, there's been technologies using similar science as us, using temperature, that the idea is, if you could just sense a hot spot, which is a beginning of a wound forming before it actually presents, that could be helpful. But those have always been plagued by challenges with adherence. I think that was really, when you think about like, what are we going to really try to solve, the challenge, the problem wasn't going to be amputations or diabetes. It was really, how do you build a very high engagement, high adherence type of a system, so you can get the patient to get the data we wanted from the patient's foot.
Can you share with us a little bit of information about cost? How much does it cost for an episode of somebody who has a foot ulcer because of diabetes,
Yeah.
and what's the total annual Medicare spend?
So a single amputation can cost as much as $100,000. We've heard cases in the VA that can exceed over $1 million in lifetime up to that date. We would hear anecdotes of that. That's an extreme, of course, but
Wow.
we can put a lot of expend in just all the follow-on procedures, graft product, all this parts. The VA announced earlier this year they're probably spending around $3.2 billion just in direct payments to foot ulcers per year, and probably estimates range anywhere from 20 to 70 billion as a U.S. healthcare system each year. I think the different studies have looked at it different ways. Clearly a big number, though, when you look at the problem in totality.
That is absolutely amazing that kind of money is still being spent on something like this, which I think most people, I shared in my introduction that many people probably think, hey, if you have diabetes today, you take insulin, you take some form of medication, it's under control. And I think most of us are surprised to learn that there are all these really significant complications from diabetes, and how much money is expended upon it and how many lives are lost to it.
Yeah.
Incredible.
It's a challenging condition, and again, this patient is often, this particular patient is just overwhelmed by all the things that we throw their way, and we're really just trying to figure out how to best reach this patient and work with them to improve their care.
For sure. So let's talk about Podimeditrics, because you have done something that I think is simply brilliant. When you and I first spoke, I think about 6 or 7 months ago. So why don't you just describe what is it that Podimeditrics does and why it's different, why it's going to help solve this problem?
As a whole, Podimeditrics is a virtual care management company, a tech-enabled one. I'll explain that in a second, but we're trying to affect the outcomes and actually try to drive, keep patients on their own 2 feet and try to keep patients out of the hospital, out of the ER. And what it is we have an in-home smart mat that we ask them to step on it for just 20 seconds a day. And with that interaction, we're going to collect the data we need to start to build a model of this patient's foot. And if we see any signs of any complications coming, we have a nursing care management function that can then work with the patient and try to coach them to do preventative care, as opposed to waiting for it to occur and do some sort of treatment care afterwards. It's worked well. We usually work with health plans to try to go after their most vulnerable patients, not just patient. It's this multiple comorbidity patient.
So if you suspect that an ulcer is forming, what type of preventative care does the individual engage in?
If it's going to be an inbound foot ulcer that's coming, It's often fairly straightforward. You just have them walk less, be a little bit more mindful of their foot. If they see any early signs, come in then, but they need to know, like, be really on the lookout, be very vigilant. And of course, if that signal persists, then we just escalate them to be seen by the clinician then, instead of, again, waiting for it to have occurred as it normally would.
Can you dive a little bit deeper into the mat? 20 seconds a day just is amazing to me. What exactly does it do? How does the technology work?
This particular patient, it was a recent study came out in JAMA, like maybe 5-6 weeks ago, as the time that we're chatting now, and it blew me away. It said 41% of Medicare beneficiaries lacked access to either an internet connected phone or computer. And this is the patient population we really want to help the most, and they just often don't have the technology they need. It's not like you can give them a bunch of wearables and hope that they're going to use it, or give them smartphone apps. That's not this particular population. It's a very, very vulnerable population. For us, 20 seconds a day. It's the mental model that they've known before, a scale. It's a very simple proposition that we offer to them, but by doing so, we create a real partnership. And then that's my best stat actually probably isn't the temperature data we have. The best parameter isn't the temperature data. It's probably adherence. The really, really high adherence signal allows us to intervene if there's any sudden changes in that. Allows us to be way more proactive that something is going on, and for us to reach out and see what's going on.
So the mat itself captures the temperature of the foot. Is that what it's doing?
Yeah, the core parameter that the mat collects is it's a two-dimensional mapping of temperature across the surface of the foot. And what we're looking for the case of foot ulcers are the early tissue breakdown. The body responds with an inflammatory response. That's an increase in blood flow to the region, and we see that as a hot spot on the foot.
Okay, that's very, very interesting. And what's even more interesting is what you said is probably the biggest indicator is lack of adherence. Something's going on, right?
Something's happening. That's right.
I always like to say it's not what I'm doing, it's when I stop doing it that is when you ought to be concerned, right?
That's exactly right. They'll have a pattern. They'll have a way that they go on with life, and that changes. It could be nothing, but it also could be something significant.
So is your mat an FDA approved device?
There's a million ways you can take products to market. I'm a physician. Maybe I'm a little bit more ingrained to do a rigorous pathway. So we absolutely did go through the FDA. I just wanted I liked the rigor. I liked then, offering to our partners the comfort that we went through a process where they're really gonna. It's not just registering, right? They're going to go through our data to really want to make sure this is safe, effective, that it has. It's a good system for the healthcare system.
So, Jon, can you go into just at a high level the FDA approval process, because a lot of our listeners may be wondering what that's like. I understand that it's not an easy process, and certainly that's to protect consumers. So that's number one. And then number two, I also understand, at least until recently, I believe there was an executive order, but when the FDA approves something, it doesn't automatically mean that Medicare approves. And I heard this term, right, the valley of death, which is in between when the FDA approves something and Medicare actually approves something, so you can actually get paid for it. So the FDA process at a high level, and then this valley of death, if you will.
Yeah, maybe the valley of death, while we're on it, FDA makes sure the systems are safe and effective, but not cost effective. They're not always looking at all the clinical data, and I think their colleagues across the hill, or however you want to describe it, when they're looking at systems, there's more to it than just, is it safe and effective? They really need to make sure that it makes sense to offer it, to all the Medicare beneficiaries out there, or even for payers thinking about other, populations of people. So that's probably the big difference. And we can talk a lot more about, I think, like some of the hurdles, why it's tough to get through a Medicare, type of a process. But to get through the FDA, there's really three ways you can do it. There's class 1, which is essentially is registering your product. There's not a lot of rigor there. Class 2, which is more or less getting your system cleared. And then, class 3, which is approved. And so to be precise, we went through clearance, they call it a 510K process. And in doing that, they're going to make sure, they're going to want to see data. They want to make sure it's accurate. They're going to go through whatever questions that they determine are the questions that need to be answered. And then coming out of it, you get your clearance. I think the FDA gets a bad rap sometimes. I think we're told as entrepreneurs to avoid the FDA, stay away from them. To me, I found them to be extremely helpful. We took calls with them in advance. There was no mystery. They told us what they're looking for. We had a lot of really good feedback there. We went through the process. Once you're just willing to engage with them, they want the same thing. They're not trying to put out things too quickly because there's this safety and efficacy concerns. But if you work through their process, it's not as bad as I think many entrepreneurs get told by various people.
I was on a call with a group of young professionals just yesterday, and we talked about regulatory and compliance. And I said, keep your regulators close. They can actually be very helpful. And most people are taught to avoid them because, they're bad. They're going to come in here. They're going to audit. But if you really develop a working relationship with them up front and have that ongoing interaction, you'll find the process to be much smoother, fewer rejections, fewer errors that you have to correct because you get what it is that they want, and you're not just trying to read words on a page and try to interpret.
I think we were told that these evil people, the FDA is just going to come in. They're just going to be irrational. They weren't at all. We had people there. They're in the military officers. They were just unbelievable partners for us to really think through the challenges. I found them to be a wonderful group to work with. Maybe that was irregular, but I don't think that is. I think that they're there because they also enjoy the process of getting good tech to the market.
Absolutely. They want to bring new things that can help people to the market as well. And thank you for your insight on Medicare, because you're right. The FDA doesn't necessarily look at whether it's cost effective, and Medicare they have a budget to worry about. So that makes a lot of sense. So thank you. Now, you do have a care management component. So could you share a little bit more about your care managers and what they do and how they benefit? And are they really the biggest driver?
Well, it's such an interesting question. We hear the phrase remote patient monitoring a lot, or connected health, or connected care. I think that latter one is the most exciting to me. It's not just let's give them a monitor, let's hope they use it, let's see what it can do, and hope the doctors are looking at that data. The promise of connected care is we give them a system plus all this extra support. We're actually a services company. We look at us. We're not a hardware company. We're not a device company. And it's that engagement, the relationship that we create, that drives probably most of the value of the system. There's been other temperature. There was just a massive randomized control trial that just came out looking at a temperature device. It showed no difference. And a lot of it, again, is you're just giving this device and hoping that they use it. I think the real opportunity for healthcare is to give them systems and engage with them to make sure that we feel we're making a partnership, or working together to try to affect outcomes.
Well, if you are using a device such as yours and you are adhering to it, I think having that human support, and if you are having successes, as an example, you want to share that success. You want to be able to have somebody to talk to encourage you to continue to do the right thing. It's hard when you're not seeing a result. It's like people always say blood pressure medication is silent. You don't necessarily feel whether it's working or not. So a lot of people give up and say, why am I taking this? I don't necessarily feel any different. So it's always helpful to have that human interaction to keep that encouragement going. It's
so true. I think we have a bias in healthcare. We used to call it poor compliance, as if they're not complying with the therapy we do. And I think that's not giving them the respect that, of course, that they deserve, or even acknowledging some of the challenges they have. And by adding on our nursing team, they're wonderful. We get a chance to really understand what's happening to them, and that extra context information is what allows us to do the outcomes that we do. A really important point is that you really do have to understand the context in which your member, your patient is interacting, so you can understand and head off something that might be coming down the pike. And if they have that human interaction, and you can understand that something has happened in the home, there are a lot of triggers that will throw people off their normal pattern pretty quickly. So having that human interaction certainly has to help from that perspective. It's critical. It's the best sensor in the world is an intelligent, curious, caring nurse. They're going to know what to ask about. Great statement. So are you able to share some results with us who maybe you've worked with and what the outcomes have been? Sure. We just recently we had a paper come out looking at Kaiser Permanente's Mid-Atlantic region. So a big health plan. Here was a particular area where they had a lot of high-risk patients. And the results were pretty exciting. For us, we We have the device, we have nursing support. What we saw was complete elimination of all major amputations. That's the first big stat. The reason why I think that's so exciting is I believe over half of them had already had a partial foot amputation before they came into the program. These were very, very high risk patients. It wasn't like we were taking very low acuity and we said, well, there's no major amputations. In the highest category, the highest population risk population they had, major amps went to 0. We dropped inpatient utilization by 52%. So over half of the hospitalizations were prevented using the system versus not. And a lot of that had to do with, if you catch them early, you have a chance to prevent the really big ones that cause hospitalization and of course amputation, et cetera. We dropped ER visits by 40% and outpatient visits by over 25%. So that was the real thing, is once you build this relationship with the patient and you start to see what's all going on in this patient's life, we have the chance to do something preventative care as opposed to having to be seen in the ER or the hospital.
Well, that is music to a health executive's ears, because you have both cost savings and really fantastic outcomes. So that's the optimal. That's what every good healthcare administrator is trying to achieve. Jon, during COVID, did you see anything different? Were there challenges that you and your team faced with this population that were exacerbated from the virus?
It's been such an interesting time, probably across every sector I'm sure every sector across the planet. Now, healthcare, we were hit in unpredictable ways, and you can imagine the challenge. This is a patient that the results I just shared with you, that was when there wasn't a pandemic. That was with KP, fantastic preventative care firm. That was with full prevention on board, and then we showed efficacy on top of that. Now with COVID, all our clinics are basically shut down, especially in the first run, or now they're maybe open with limited throughput. This patient absolutely relying on preventative care now either can't get a clinic visit, or they're just frightened to leave their home. They're not wanting to go to the healthcare system to potentially get COVID-19. So amputations, no surprise, was a paper in Diabetes Care that came out that said amps were 3 times now more likely to happen during it compared to the 1 year prior. So for this patient, this was a very scary time. On top of that, we're trying to get the whole system to jump to telehealth, and telehealth is a one-to-one modality. One clinician, one patient at a time. And that really isn't scalable in the very patient population who needs it most. Again, this patient population, 41% didn't have a smartphone or even a computer that could do it. So suddenly, the world needed this virtual care system that could do a one-to-many type of monitoring environment where you can monitor a whole population. And in my opinion, it's just important to know who to talk to is who you don't have to talk to. And we had spent the last year moving completely virtual. It wasn't like we were planning for a pandemic. We knew that's the direction the system was going. And we were, drop of the hat, we were ready to start to onboard patients and monitor and take care of them without them ever having to leave their home. So we saw a big bump in growth. It was 300% growth compared to the period before when COVID really started to bump up. And I think a lot of it has to do with that challenges with telehealth being challenges scaling in this patient population. The need to monitor this patient from the home. This is the same patient that's super high risk for COVID-19, right? Obesity, age, heart disease, diabetes. So it was just a perfect storm to really need virtual care systems like ours. It was an amazing time.
Jon, some people believe that patients are not very accepting of remote patient monitoring. Why are they accepting of your service?
Yeah, there's a lot to that. I think there's a lot of worries about Big Brother and privacy. There's a lot. This is my dad is a Vietnam era veteran. There's often even distrust of the system. Who's monitoring these data? I think for us that relationship was everything. They fear loss of, the number one thing that they talk about in the literature is loss of control, that the diabetes and all their comorbidities have taken over their life, and they feel powerless, hopelessness, high rates of depression as a result, as you can imagine. And I think our ability to partner with them and give them that feeling of control, that idea that we're going to do this together, that we're going to keep an eye on it. Hey, if we see something, we're going to work on it together to get rid of the episode. That's probably been the number one reason why we've been trusted so quickly and so broadly across our population. I think in the VA, a very challenging patient population, over 75% of our veterans are fully engaged in the system at 1 year. Intention to treat, everyone being included, 75% are still fully engaged in the system. I think that's a testament to this this relationship, this trust that we can build with this patient.
Well, there are two things that I heard in there. Number one, you serve as a co-pilot, not the pilot. And I think that that's really beneficial because people do want to be in control of their health. And even though their conditions may be very overwhelming, that feeling of loss of control is just even more overwhelming. The second thing is you have really developed something that takes 20 seconds out of their day. It's something that can fit into their routine. So classic example of really developing something that is so simple, so easy to use, and fits in their life. They don't feel like they're stepping out of their routine to provide you with something. It's, oh, well, I just got out of the shower. I'll step on the mat. Simple, easy to do. So congratulations on that. That's really exciting.
I appreciate it. It took us a lot of futzing around with various ideas to get to this type of a mental model. I remember early on there were support groups we go to, and we had like blue foam. You get camping mattresses from Walmart. We cut them in shapes, and we tried shoes and insoles and socks. And this mat, though, there was something to it, and thankfully we just kept at it, validated that was something we'd get a high adherence, and it worked out very well for us.
Well, what's great about this population is they'll tell you if they don't like something.
They're very empowered. They're going to say, this is not for me. And, okay, well, how about this shape? How about this?
John, one other question about this population. Is there a correlation obviously between, or I shouldn't say obviously, I'm asking the question, is there a correlation between lifespan and whether or not you get a diabetic foot ulcer? Is your lifespan likely to decrease if you get a diabetic foot ulcer?
It's a little bit of, I'll say, selection bias. The patient who gets a diabetic foot ulcer is a patient who's had diabetes, probably with challenges controlling their glucoses for a long period of time. And along comes with that coronary artery disease. They're often smokers and have COPD. Our patients tend to be in the 50s and 60s. I don't see as many patients in the 70s and 80s because of just the burden of complexity that they have. So it's not the really old patients that usually get it. It's a very complex patient in the 50s, 60s, et cetera.
Got it. Okay, that's helpful. Now, because you do have the care management portion to this, many health plans have care management for individuals with diabetes. Do you come in as a replacement to that, or is it a supplement to what the health plan is also doing?
In the beginning, many of the health plans we were working with, and we were really designing the system, they wanted to do that whole part. And it was actually the health plans that said, our care managers are overloaded. Can you just take it? And we really built our system because of that to be completely vertically oriented. What we also know too is, as since we know thermometry, we know the signal we're extremely well trained on exactly this. We just do it better than these teams that have a million things that they got to be trained on and do. So now they really just outsource that whole loop to us, and then we integrate into their system, as needed.
Yes, I would imagine that you really want somebody that has expertise in reading that information. You don't want to make a mistake.
That's right.
So, John, have you thought about extending this product to other conditions? Is it extendable?
It's interesting. Once you get this patient to engage in a platform, in a system, there's so much work that you can do for this patient. I think the challenge has always been, how do we connect to this patient to offer care? The Mat form factor is one that you can imagine is very easily redesigned to add in additional parameters. And we can also add on more services. To me, we started with the diabetic foot, and now we're already seeing impact on, like I said, heart failure, COPD. This patient population is very vulnerable and very, the patient population that needs more attention. The amputation is probably considered the single greatest marker of health inequity that we have in the United States. Black Americans are 3 times more likely to suffer an amputation than white Americans. That's crazy. This is the patient population that the healthcare system just hasn't figured out how to get to. And we're trying anything we can to move the needle, improve their care, and reduce costs for this population.
Well, the really unique thing that I see about what you're doing, John, that is something that health plans, I think, really need to consider, and hospital systems as well, is you are interacting real time because you have this real time data coming in. And this is why remote patient monitoring is just so critical. You're able to intervene quicker. Unlike many health plans where the care managers, who are just great individuals with large patient loads, are calling people from their list, from their caseload. But I may call you on a Tuesday, but it was Saturday or Friday where the signal started occurring. So having this real-time data is, to me, that's the key to allow for that early intervention. Because what I would want a case or care manager doing is, sure, having a list, but having that real-time data come in and say, oh, guess what? We're going to bump John up to the top of the list. You need to call him in the next half an hour instead of 2 days from now because of this measure, or because he hasn't gotten on the mat in 2 days. That, to me, is what the unique feature is that I think will just prove to be beneficial, especially if we can determine through remote patient monitoring the many other conditions that it can be applicable to.
It really flips the model. It flips it from, one-to-one intermittent care where, like we make appointments, we come in, how are you doing at this moment, to a one-to-many sort of passive monitoring of a population and with on-demand care. The moment there's an issue, we connect with that patient, we reach out to them. We don't, we get out to them when and not have to, like, again, they're often overwhelmed. It allows us to, at that very moment, impact their life in a very specific and meaningful way.
And as you think about it from a scale perspective, when you have this type of data, now, quite frankly, your caseload can get bigger because the data is directing you to where the need is. And just having these random calls because somebody is on your list doesn't have to take place anymore. You get the data in on a real-time basis and say, here's my list for today based upon what the data is telling me in a real-time basis. It's fantastic, John. What you're doing is just amazing. And as I began to investigate the implications of having a diabetic foot ulcer, you're not only saving extremities, you're saving lives. So kudos to you and your team for really tackling a tough issue.
Appreciate it. And we're excited to be at this spot. And it's amazing to finally see its impact on populations, everything we had hoped to do when we started off, and now we get to see the results in hand.
So John, we like to ask all of our guests, what books have they been inspired by, or maybe that they're currently reading, and what podcasts are on their playlist? Can you share with us?
Oh my goodness. Well, I'm a definite, I take my data comes in via books. I'm old school. Occasionally I have a Kindle. I try to use it, but something about holding the book and then putting it in a bookshelf is something remarkable about that. And I'd say probably the book, I haven't thought about it this way. The book that really set me on a path that I remember reading when I was on breaks as an anesthesia resident, and I reread it recently, was Good to Great. It's a crazy book. It's one about it demands the question, what can you be best at in the world, and then with that relentless focus, how can you use it to really change, in their case, a good company to a great company. I find it also hysterical because they talk about why Circuit City is one of the greatest companies in the world when it was written. Of course, now it's vaporized. A little bit of humor when you read it. The other one would be a very recent read, What You Do Is Who You Are by Ben Horowitz. It's an amazing book on culture, and I think you should be managing that as much as you're managing your technology development or your people. It's just an unbelievable impact. Why are we here? What are we trying to do? It was an amazing read. Ben's a smart guy.
Any podcast?
I'm low tech. I'm maybe more like our patients than many other hip people. And I wait for it to come out on the books, and then I'll read it then.
Well, maybe you should start by just listening to B-Time. Just start with one.
B-Time is my favorite of all the podcasts, though. It is the podcast.
Jon, thank you so much for being here today and sharing your story and what you and your teammates at Podimeditrics are doing. Just astounding actions that you're taking to really help people with diabetes live a healthier, better life. So thank you.
Thank you so much for having me here. It's been an exciting time just to get to share some of the work we've been doing. Really honored. Thank you.
And for our audience, that's it for another episode of B-Time. We'll be back in a week. Thank you.